So at the outset, on behalf of Department of Neonatology, I welcome you all. And it is our privilege to present this CGR in front of Lieutenant General Madhuri Antika ma'am. And it is really an honor to present this CGR. The topic for today is high frequency ventilation in neonates. This presentation is moderated by Dr. Abhijit and Dr. Anita, and our residents, Dr. Arohi and Dr. Shweta, who are DMs senior residents first year, will be presenting this CGR. So just to tell you about the overview of the presentation. High frequency ventilation is the most advanced form of ventilation in which we use frequently as a rescue mode in newborns with respiratory failure. It is different from conventional ventilation in the form that we use supraphysiological rates and low tidal volume in order to prevent the ventilator-induced lung injury. We will be covering our presentations with some introduction, some interesting case scenarios, followed by our departmental experience. So I welcome you all. Dr. Abhijit, please take over.
Good morning, everyone. Let's dive into the integrated realm of high-frequency ventilation in neonates. So we will talk about a brief overview, followed by case beginnings, then literature review and departmental experience. As we know that respiratory failure is quite common in the newborn and at times very serious clinical problem, and considerable proportion of these infants require invasive mechanical ventilation, which acts as a bridge therapy till the restoration of optimal lung functions. So this ventilation comes with few side effects. Optimal outcomes can be achieved if appropriate strategies are used based on the patient-specific pathophysiology. So the unit protocols and guidelines can be useful, but then ultimately the patient care has to be individualized. Basic modes of mechanical ventilation include intermittent ventilatory ventilation, synchronized intermittent ventilatory ventilation, assist control mode, and pressure support ventilation, and volume control ventilation. So as we know that ventilation comes with some adverse effects. This include ventilation-induced lung injury, which can be in form of barotrauma, which is due to the high use of high pressures, or volutrauma, where the high volume swings, tidal volumes can cause lung injury. Then there can be atelectasis due to the repetitive opening and closing of the alveoli. And all these leads to form the soil for bacterial seeding and lead to biotrauma. So as we can see that this is the rat lung model. This is the normal lung. Then this is due to the atelectasis due to an inoptimal PEEP use. And then there is over-distension due to high pressures. So the appropriate strategy is to keep the lungs open and keep it open. That means we have to keep the alveoli recruited and prevent it from de-recruiting. So for this, newer concept has come, high frequency ventilation, which is a lung protective strategy. Now I invite Dr. Arohi for the historical perspectives and core concepts of the high frequency ventilation, followed by case studies.
Thank you, sir. I would like to carry the discussion forward. So if we go down in the history, in 1950, Dr. Henderson, he laid the foundation of high frequency ventilation, which we do today. So he observed the panting dogs. He observed that when the dogs are exposed to acute heat stress, they breathe at very fast rates that are supraphysiological with low tidal volumes, and still they are not hypoxemic or hypercapnic. So he mentioned that tidal volume less than the dead space can also be effective in gaseous exchange. So this is a landmark experiment done by Dr. Henderson, and this was published in the American Journal of Physiology, where he mentioned that CO2 elimination is still possible even with low tidal volumes, even less than dead space, and with supraphysiological rates. So he did smoke studies, basically. He used a tobacco smoke in a glass tube. So when the smoke was blown in the glass tube, he found that convection penetrated the smoke deeply through the tube, and this effect was known as flow streaming. So the smoke, if with the faster puffs, the smoke remained in the center part of the tube. And when later on the flow was stopped, there occurred radial diffusion. So there was instantaneous mixing of the gas. So after the study by Dr. Henderson, it was in 1950 to 70 when Dr. Emerson, Dr. Bird, and Dr. Bunnell studied high-frequency ventilation. And in 1970, success was found with the animal studies. In 2000, high-frequency ventilation was used for the adult population, and in 2013, nasal high-frequency ventilation was introduced. So high frequency ventilation is a modality of mechanical ventilation with rapid ventilatory rates and small tidal volumes. These rates are supraphysiological, which range from 2 to 20 Hertz. That means 120 to 1200 cycles per minute. There is attenuation of pressure and volume swings within the distal airways and alveoli, which leads to less of barotrauma and volutrauma. It is used in a variety of conditions, either as a primary mode or as a rescue mode, and it utilizes the optimal lung volume strategy, that is open lung strategy is used. So this image is showing the basic principle of the piston oscillators. So there's an electromagnetically operating piston which moves back and forth and creates oscillations in the pressurized gas. This is the port from which the bias flow enters the system. That is, a very high flow of gas enters the system to prevent CO2 breathing. And this is a low pass filter through which the expired gases, they leave the system. Now this high pressurized gas in the form of oscillations is entering the lungs. So there are various types of high frequency ventilations. It can be oscillatory ventilation, jet ventilation, or there can be flow interrupters. So the basic difference among the different types of high frequency ventilation lies in the fact that how the oscillations are being produced. So in the oscillatory ventilation, there is an electromagnetic piston, as we discussed, which generates the oscillations. In jet ventilation, there are basically bursts of gases which are propelled into the airway with the help of a pinch valve. And these oscillations enter through a narrow nozzle. And in the flow interrupters, there is a solenoid valve which produces the bursts of gases, and there's a flow interruption. All these modalities have the ability to superimpose psi breaths to attain sustained inflation, and these are the various mechanics shown. So the general principles are that it is a CPAP system with piston displacement of gas, which produces small tidal volumes in the range of 1 to 3 ml per kg, which is even less than the dead space of the airway, with high rates, and also there is decoupling of oxygenation and ventilation, which is a unique phenomenon in high frequency ventilation. Also, the expiration is active. These are the various ventilators which provide high frequency ventilation. So the ventilator which has a piston mechanism only can provide a high frequency ventilation. Now, if you see the difference between the conventional ventilation and high frequency ventilation, in the first image, we can see there is repeated opening and collapsing of the alveoli. Now, this leads to atelectrauma, shear stresses, and injury. While in high frequency ventilation, we can see there is a sustained inflation of the alveoli. So this is the goal, what we want to achieve. So it works on high mean airway pressures and minimal tidal volumes. Now, in this video, we can demonstrate the difference which we discussed. It is a balloon model. This is a balloon model which represents alveoli in the lungs, and this is the windpipe. So first I will demonstrate how alveoli open and collapse during conventional ventilation. Now I will demonstrate how alveoli remain recruited in high frequency ventilation. So this was our effort to make it more understandable. So now we can see in high frequency ventilation, that is the first image shown here, there is pressure attenuation. It shows that the amplitude which is being delivered gradually attenuates, and this less of pressure swings reaching the alveoli in the distal airways, while the mean airway pressure remains constant throughout. And this is the pressure volume relationship shown here. So this is an inspiratory curve and this is an expiratory curve. And there are two zones. One is the zone of atelectasis and the other is zone of overdistension. So our goal is to ventilate in the safe window for the babies. And high frequency ventilation helps us in ventilating them in the safe zone. Now, these are the in vivo microphotographs of alveoli showing the dynamic behavior. The first one is during conventional ventilation, showing the repetitive opening and collapsing as we discussed. And the second one is showing a sustained inflation of the alveoli. Now, how does it happen? There are different mechanisms of gaseous exchange which are occurring in high frequency ventilation and which make it different from conventional. So the oscillations which are produced, they create eddies, and there occurs turbulence of gas flow in the airways. So the gaseous exchange occurs by different mechanisms in the different areas. In the proximal airways, it is basically the bulk convection mechanism which is helping in the gaseous exchange. So oscillatory pressure applied at the airway opening gets dampened by the resistance of the tracheal tube and central airways. In the middle airways, it is both convection and diffusion which is operating. And in the distal airways, it is mainly the diffusion process which is helping in the gaseous exchange. So the bulk convection is basically, it means that there's a large movement of the gaseous molecules due to the high pressure gas which is propelled into the airway. And it also leads to the aeration of the near alveoli which are near to the proximal airways. In the middle airways, tailor dispersion is the main mechanism, and this is the fundamental basis of high frequency ventilation. So when the gas is propelled at such a high rate and at such a high force, this is the inspiratory gas which takes the form of an arrowhead. And this inspiratory gas lies in the center of the tube, that is the airway, while the other part is showing the expiratory gas. And once the flow is stopped, there is occurring instantaneous mixing of the inspiratory and the expiratory gases. Now, molecular diffusion occurs at the level of alveocapillary membranes, and this is basically showing the diffusion of gases across a concentration gradient, as the inspiratory gas is rich in oxygen and the expiratory gas is rich in carbon dioxide. Collateral ventilation is occurring via the pathways between the alveoli. These pathways are also known, which lead to the intercommunications. And pendulum mechanism, basically it means that different lung units have different compliance. Some parts are atelectatic, some are overdistended. So there is occurring gaseous flow between these different lung units as well. So the unique phenomenon in high frequency ventilation is a decoupling of oxygenation and ventilation. So oxygenation is being maintained with the help of mean airway pressure and the fraction of inspired oxygen, that is FiO2. While the ventilation is maintained with the help of amplitude, it is the force with which the piston is operating, and it's moving back and forth. And the frequency, this is helping in a CO2 elimination, and this maintains a tidal volume. So in this graph, we can see that this center line is showing the mean airway pressure, and this distance between the peak and the trough of the oscillations is showing the amplitude. So mean airway pressure helps in recruiting the alveoli. It is a continuous distending pressure which is created with the help of the bias flow. And the FiO2 helps in maintaining the oxygenation, and it has to be titrated as per the saturation targets. In the ventilation parameters, that is the parameters helping in CO2 elimination. They are frequency, which is determining the CO2 removal, and it depends upon the lung compliance. So higher frequency leads to delivery of lower tidal volumes, and lower frequency delivers higher tidal volume. So there's an inverse relationship here. And amplitude is the force and distance with which the piston moves from the baseline. It is clinically demonstrated as a wiggling response. So in this video, we can see the diffusion coefficient of carbon dioxide is another parameter in this ventilator, and it is a square of tidal volume and frequency. So it predicts the chances of normal carbon dioxide levels, and it is important to monitor the trend of diffusion coefficient of carbon dioxide during ventilation. This is to prevent the excessive CO2 washout, which may be harmful for the preterm babies. It varies as depending upon the disease etiology and the compliance of the lungs, and the requirements are lower if the baby is breathing spontaneously. So the various indications of high frequency ventilation are the failure of conventional ventilation, persistent pulmonary hypertension of newborns, respiratory distress syndrome, administration of inhaled nitric oxide, congenital diaphragmatic hernia with pulmonary hypoplasia, and air leaks. So the failure of conventional ventilation is said to happen if we reach plateau pressures of greater than equal to 30 to 35 centimeters of water with severe respiratory acidosis, that is pH less than 7.1, or PCO2 more than 60 millimeters of mercury. The oxygenation failure happens if the saturations are still less than 90%, despite FiO2 of more than 60% and optimal pressures, or if the oxygenation index is more than 15. So the initial high frequency settings, the mean airway pressure should be initiated at 2 to 3 centimeters of water. Above that was on conventional ventilation. And the amplitude should be 2 to 3 times of mean airway pressure, which is subjectively demonstrated as a wiggling response. And frequency in the term babies ranges between 8 to 10 hertz, and in the preterms between 10 to 15 hertz. And FiO2 begin as per the requirements on the conventional ventilation. It should be higher than that and titrate as per the oxygen levels. So for monitoring, we need to assess the wiggle. The acid blood gas analysis should be done for the adequacy of ventilation. Chest X-rays should be done to assess the aeration. So for an adequate aeration, at least the X-ray should be between 7 to 9 reps. And the amplitude, frequency, mean airway pressure, and other settings are titrated as per the blood gases. Also, the assessment of hemodynamics is important. because since we are giving high mean airway pressure, it can lead to decreased cardiac preload or hypotension. Now for the weaning process, the disease process must be improving. First of all, there should be normal blood gases, electrolytes, hemodynamic parameters. The FiO2 requirement should have come down to less than 60%, and the mean airway pressure should be decreasing in a stepwise fashion till at least less than 18. Now, once it is less than 18 and FiO2 is less than 60%, we can decrease mean airway pressure and FiO2 in tandem to at least FiO2 less than 30% and mean airway pressure less than 14. Further, we can plan extubation or changing to conventional mode of ventilation. So failure of high frequency ventilation, if ventilation deteriorates even at 5 Hertz, that is at such high tidal volumes also, if the baby is not maintaining saturation or is hypercapnic, then we will consider the failure. And if you have to check whether the amplitude is maximum or the MAP is optimal. And also, if there is no improvement in ventilation or oxygenation in 2 to 6 hours, then we would consider the failure of high frequency ventilation. The complications can be hypotension, shock, air leaks, or necrotizing tracheobronchitis. Now we'll discuss some case vignettes to understand the utility of this ventilation modality. So in the first case, this was a late preterm baby born at 35 plus 2 weeks of gestation with birth weight of 2.2 kgs and was outborn baby. Baby was born to a primary gravida mother, but antenatal ultrasound was showing polyhydramnios. So baby was diagnosed as tracheoesophageal fistula type C on day 1 of life, was operated on day 3, and further was discharged on day of life 30. But on day 45 of life, baby had recurrent vomiting episodes and was diagnosed with esophageal stricture. Hence was referred to our site. So in the initial course, baby underwent serial esophageal dilatations due to the stricture, and this was followed by stricturoplasty here in our institute itself. And on post-op day 3 of the surgery, baby had type 2 respiratory failure requiring intubation and ventilation on conventional mode, that is SIMV mode. The chest X-ray at that time was showing right-sided pleural effusion and bilateral infiltrates. Anastomotic leak was suspected, hence the corrective repair in the form of esophagostomy and gastrostomy was done. But baby still had persisting respiratory failure even on maximum ventilatory settings. Hence, baby was referred to NICU, was shifted here. So on admission in NICU, baby was euthermic, heart rate was 166 and was shifted on intermittent positive pressure ventilation. The saturations at that time were 81%. So baby was not maintaining saturation and the air entry was markedly decreased on the right side. There were bilateral coarse crepitations, and on admission, the blood gas was showing a pH of 6.901 and the PCO2 levels were 53 millimeters of mercury. So baby had such high respiratory acidosis. So on the initial settings in an ICU, the mean airway pressure was kept at 18, that was kept 2 centimeters above that on conventional ventilation. The amplitude was 60, the FiO2 was 100%, and the frequency was 9. Now in the first graph, we can see the trend of carbon dioxide levels, amplitude, and frequency during the NICU stay. So the initial carbon dioxide levels were around 150, which gradually declined after the initiation of high frequency ventilation. And at around 48 hours of life, we were able to maintain normal PCO2 levels between the normal range, that is 35 to 45 millimeters of mercury. The amplitude was initially 60, which was gradually decreased to 40 to 45 as per the Wiggle response, and frequency was more or less kept constant. For the ventilation aspect and the oxygenation part, we can see the second graph, that is the mean airway pressure, which was initially 18 and was then gradually declined to 14. So there should not be drastic changes in the mean airway pressure because it can lead to de-recruitments. And the saturation, which was initially baby was not maintaining, it was around 80%, it gradually improved. And we could then taper off the I502. These are the serial X-rays of the baby. So initially we can see that there was right-sided pleural effusion, there was consolidation, bilateral infiltrates were there. But gradually during the hospital stay, the X-ray improved, the aeration improved. And on day 60 of admission, baby had well aerated lung fields. So during hospital stay, for the respiratory part, on day 14, we had weaned off the baby from high frequency ventilation to conventional ventilation. And on day 26, we could initiate non-invasive ventilation in this baby. Day 14, baby was shifted to hyperoxygen therapy and was on room air by day 60. For sepsis part, baby had sepsis and pneumonia, so required multiple antibiotics during hospital stay. And also initially there was anemia, thrombocytopenia. Hence we had to give PRBC and RDP transfusions, but later on the platelet levels improved. Also, there were some electrolyte disturbances like hyponatremia, hypokalemia, which were corrected, and the maintenance was given in the supplementation. And the baby went into shock on day 6 of admission. That time, septic shock was suspected, antibiotics were upgraded, and then remained hemodynamically stable. The inotropies were tapered off after 6 days. On the nutrition aspect, we had to give total parental nutrition initially for 14 days, and then later on, minimal enteral feeds were initiated and were gradually increased. These were gastrostomy feeds. So in the ward, the repeat cultures sent were sterile, MRI brain was showing no significant abnormality, and the hearing screen was bilaterally passed. Baby was on minimal oxygen therapy in the ward. Now, at the time of discharge, baby was maintaining saturation on room air, was hemodynamically stable, was accepting gastrostomy feeds, and was gaining weight. So the weight, length, and head circumference was still less than third centile since the baby underwent a stormy course in the hospital. Now, in the second case, this was a preterm baby born at 30 weeks of gestation with a birth weight of 1500 grams. Baby was born to a 30-year-old primary mother, and it was an unbooked pregnancy. Hence, antenatal steroids were not covered, and she had cervical incompetence with preterm premature rupture of membranes. So, a preterm baby at 30 weeks was born with labored breathing at birth. So, in the delivery room itself, baby had marked retractions. Respiratory rate was 76 per minute, and there was decreased air entry with audible grunt. The delivery room CPAP was initiated, and the Silverman-Anderson score was 7/10. Hence, baby had required intubation in the delivery room. The cord blood gas was showing a pH of 7.102. The CO2 levels were 66.8, that is, the baby is having respiratory acidosis. PaO2 was 21.2, bicarb was 17.9, and base deficit was -6.7. So respiratory distress syndrome was suspected. It is a leading cause of respiratory morbidity and mortality in the preterm neonates, which is also known as hyaline membrane disease. The incidence is 1% of total live births in US and 2.42% in India. It is basically due to deficiency or inactivation of surfactant, which leads to the onset of respiratory distress at birth or within 6 hours of life. So in an ICU, the baby was initiated on SIMV mode of ventilation at 2 hours of life, with the settings of PIP of 20, PEEP of 6.5, rates 45, and FiO2 was 50%. 2 doses of surfactant were given, the first one at 4 hours of life and second at 16 hours of life. Further, there was failure of conventional ventilation. That is, we reached the maximum settings, pressures of 24/7, rates of 45, and FiO2 was above 60%. So we initiated high frequency ventilation as a rescue at 26 hours of life. The mean airway pressure was kept at 14, amplitude 40, frequency 12, and FiO2 100%. So this was the initial X-ray, which is showing very poorly aerated lungs with reticular granular pattern. And we weaned off the baby to SIMV mode on day 5 of life and to CPAP on day 10. On day 16, baby was on room air. So sepsis screen sent was negative. Hence, initial first-line antibiotics were started and were stopped after 7 days. Surfactant baby had received, and the feeds were gradually increased and baby tolerated well. So cranial ultrasounds were done since the baby was preterm baby. We were within normal limit. The ROP screening was showing zone 3 immature, which was further followed up. Thyroid functions were normal. Hearing screening was bilateral pass, and pulse oximetry screening was also passed. At the time of discharge, baby was stable on room air, was hemodynamically stable, was on direct breastfeeding. The post-menstrual age was 35 plus 2 weeks, and the anthropometric measurements were between 10 to 50th centile. Now coming to the third case. This was a term baby with 3.1 kgs birth weight and was born to a gravida 3 mother. The antenatal ultrasound was showing polyhydramnios. Baby cried immediately after birth and had respiratory distress. Baby required intubation and then was referred to our center. So on admission, baby was on intermittent positive pressure ventilation. Heart rate was 176. CRT was prolonged. Saturations were 66%, and blood sugars were stable. Baby had central cyanosis at that time. Air entry was diminished on the left side. It was markedly reduced, and there were gurgling sounds heard. There were no crepitations or wheezing. And apex beat was shifted to the right. Heart sounds were normally heard. Abdomen was kyphoid with no hepatosplenomegaly. Tone, activity, and reflexes were poor. So on admission, the pH was 7.127. PCO2 levels were 68 millimeters of mercury. And there was bicarb of 15 with base deficit of minus 11.9. Lactates were 44. So this case was diagnosed as congenital diaphragmatic hernia. This is a complex disease requiring a very difficult management. So what happens is that basic pathology is a lung hypoplasia, and also there is occurring the herniation of abdominal contents into the thorax with a diaphragmatic defect. This leads to further hypoplasia of the ipsilateral lung and the variable hypoplasia of the contralateral lung. Now there also occurs increase in pulmonary vascular resistance, which leads to persistent pulmonary hypertension of newborns. There is right to left shunting, RV dysfunction, and ultimate hypoxemic respiratory failure. So there's a vicious triad of PPHN, that is persistent pulmonary hypertension of newborn, lung hypoplasia, and mechanical compression leading to respiratory failure. So this baby required intubation and ventilation on SIMV mode in view of respiratory failure, but was shifted to high frequency ventilation within 3 hours. Inotropes were added, sildenafil was also added for the management, and the inotropes were titrated in view of shock and hypoxemic respiratory failure due to PPHN. Baby got operated on day 3 of life, was shifted to SIMV mode on day 5, and the inotropes were gradually tapered off. Baby was further weaned off to non-invasive ventilation on day 10 and to room air on day 12 of life. Further got discharged on day 16. So had a favorable hospital course, and this was the initial X-ray which is showing the bowel loops here in the thorax.